Good morning, respected Emeritus Chairperson, sir, for gracing the CCR with your presence. Emeritus Chairperson, sir, respected Chairperson, sir, Vice Chancellor, sir, Jaiswal, sir, VK Kapoor, sir, for gracing this CCR. I am Dr. Nipun Lamba, Associate Professor in Department of Palliative Medicine, and today we are going to present a CCR from our department. Before proceeding, I would like to give brief introduction of our department. Our department is an NMC recognized department with annual uptake of 3 seats, and ours is the first non-governmental medical college in North India to have this palliative medicine department, and our department is among the 8 exclusive centers who are offering post-graduation in palliative medicine. We are conducting regular seminars, journal clubs, and we are also part of multi-specialty tumor boards which are conducted in SRCC. I would also like to highlight that we are an ESMO designated center. ESMO is European Society of Medical Oncology and Palliative Care designated center, and we are among the 5 recognized centers throughout the country, and also we are accredited by IAPC, which is Indian Association of Palliative Care. We provide pain management services, non-cancer pain like low back pain, knee pain, shoulder pain, as well as cancerous pain as well. We provide palliative care in our department. We provide hepatic, renal, respiratory, cardiac, neuro and respiratory supportive care, end-of-life care services, home care services, as well as teleconsultation services. Because our palliative patients are in tremendous need of continuous care, each patient which is coming in our OPD has phone number of at least one of our residents so that they can call them anytime at any hour and our residents respond to that patient. Thanks to our management, we are a well-equipped department. We are having lymphopress machine, which is used for management of lymphedema. We are having transcutaneous electrical nerve stimulator. We are equipped with PRP machine, platelet-rich plasma machine, and also we are equipped with state-of-the-art ultrasonography machine and C-arm for doing procedures. And I would like to point out every procedure which is done, even in AIIMS Delhi, is done in our institute. There is no procedure which is done elsewhere and not done in our institute. So we are at par among the premium institutes in the country. We are having all the essential narcotic drugs like morphine, fentanyl patches, buprenorphine patches. Even injectable morphine and fentanyl is also used for pain relief in our patients. We are doing cervical epidurals, trigger point injections, intravenous ketamine and lignocaine infusions, USG guided procedures, spinopalatine ganglion blocks for head and neck cancer pain, celiac plexus blocks for sciatica as well as metastasis related pains, lumbar transforaminal nerve block, knee and shoulder joint injections, PRP therapy in knee and shoulder joints, ganglion impar plexus blocks, and trigeminal nerve block neurolysis or RFA ablation. These are all the images of our patients of the procedures we have done in our institute. Also, we are providing add-on courses like certificate course in essentials of palliative care. 4 batches have passed out who have done this course since 2021, and also under guidance of Dr. Seema Khandelwal ma'am, we are doing caregiver course, and at least 3 to 4 batches of the caregiver course have also been passed out. Our faculty and residents are continuously involved, and we have achieved JMA awards. Dr. Sudha Sarna ma'am, myself have received JMA award for work in pain and palliative medicine excellence awards. So now I would like to invite.
Good morning, respected chairperson, faculty members, seniors and colleagues. I am Dr. Shivangi Sharma and I shall be presenting this case of a patient from debilitating pain to functional recovery. She is a 59-years-old female who is a teacher by occupation, a resident of Ajmer, and she belongs to the upper socioeconomic class according to the Kupuswamy scale. She presented to us with 3 months of severe left shoulder and upper limb pain associated with restricted movement, disturbed sleep, and progressive difficulty with daily activities. Coming to the history of presenting illness, this is a 59-years-old female with a known history of left-sided carcinoma breast. She has completed her cancer-directed treatment 2 years prior and remained asymptomatic during this period, until she developed swelling which was gradually progressive and showed multi-level lymphatic blockages in lymphoscintigraphy. For this, she underwent lymph node transfer surgery in 2024 and remained asymptomatic for 3 months. After this, the patient developed pain with swelling involving the left shoulder and upper limb. I'd like you to note the pattern here. The pain originated in the shoulder and it radiated distally down the upper limb, suggesting a neuropathy component. It was continuous, described as sharp and shooting, and it was severe in intensity with worsening over the last 15 days. This prompted further evaluation. In addition to pain, the musculoskeletal impact became quite evident on examination. She had a marked restriction of left shoulder movements and functionally she was unable to elevate the left upper limb. What was particularly concerning was the progressive stiffness of the shoulder joint, indicating that this was no longer just pain-limited movement, but an evolving restriction with significant functional impairment. Moving on to the negative history, she had no fever, warmth or redness and importantly no sensory symptoms or limb weakness. There was no chest pain or dyspnea and no history of prior shoulder trauma, surgery, dislocation or rotator cuff pathology. She also had no background of inflammatory or autoimmune joint disease and notably no weight loss or features which would be suggestive of disease recurrence. If we briefly step back from the pathology and look at the person behind the disease, she lives with her son, daughter-in-law and 2 grandsons, which shows a strong family support. She was separated early from her husband and has raised her sons on her own as a fiercely independent woman. For someone like her, not being able to be self-reliant was a major source of anxiety and low self-esteem. Moving beyond the physical symptoms, holistic patient care also requires an understanding of the patient's spiritual and existential concerns. In this context, I will now discuss the spiritual history of this patient. She identifies herself as both spiritual and religious with a clear Christian faith. Prayer is not occasional for her, it is a daily practice, suggesting it functions as an active coping mechanism rather than a background belief. Currently, she finds meaning through meditation, devotional reading, and quiet time in nature, activities that point towards introspection, acceptance, and emotional regulation. The patient has a non-vegetarian diet. Her bowel and bladder habits were normal with no history of addiction. Furthermore, she had no history of similar illness in the family. However, her father had coronary artery disease and her mother was suffering from type 2 diabetes mellitus. Her elder brother is a known case of T2DM and her younger son has hypertension and hypothyroidism. She is allergic to the following medications. Now let me walk you through the past medical history of this patient. She is a known case of hypertension on tablet Talma H and hypothyroidism on thyroxine tablet 300 mcg. In July 21, she was diagnosed with carcinoma left breast and underwent left modified radical mastectomy followed by 12 cycles of chemotherapy and is on tablet letrozole. In February, she underwent 3 weeks of radiotherapy and was on regular follow-up. In early 2024, she developed gradually progressive swelling in the left arm and in October 24, she underwent limb scintigraphy and reconstructive microvascular surgery. Now I'd like to invite Dr. Vikhyath from Department of Surgical Oncology to discuss further about this case.
Very good morning to everyone present here, respected dignitaries, colleagues and consultants. I'm Dr. Vikhyath from Department of Surgical Oncology. The patient initially presented to us a 59-year-old female who was a known hypertensive, hypothyroid, presented to the surgical oncology OPD with a 2-month history of lump in the left breast. On examination, a 3 by 2 centimeter lump was palpable in the upper outer quadrant at about 2 o'clock position of the left breast with a clinically unremarkable axilla. Patient underwent a true cut biopsy which was suggestive of an invasive ductal carcinoma, no special type, grade 2, with an IHC status of estrogen receptor positive, progesterone receptor negative and HER2 negative status, categorizing her into a luminal A patient. The PET-CT evaluation was done, which was suggestive of 1.7 centimeter by 2.7 centimeter FDG with soft density nodular lesion in the left breast with well-preserved fat planes with the overlying skin and the underlying pectoral muscles. Few mildly avid subcentimetric axillary infraclavicular lymph nodes were present. Patient underwent modified radical mastectomy with chemoport insertion. The entire breast tissue with the pectoral fascia, nipple areola complex, along with level 1, 2, and 3 of the lymph nodes, were removed, preserving the nerve to latissimus dorsi, nerve to serratus anterior. Meticulous hemostasis was achieved, closed suction drains were placed, and the specimen was sent for final histopathological examination. She also underwent a chemoport insertion with access through the right IJV. The cannulation was done and a right infraclavicular pocket was created for the port chamber and the tip of the catheter was placed in the superior vena cava. This is a schematic representation of how a chemoport works. This is a chemoport with the port chamber and the catheter, which is placed in the right IJV, and through a non-coring needle, which is called a Huber needle, the port is cannulated, and then the chemotherapy drugs are usually given. The advantages of a chemoport is usually a long-term venous access, reduces repeated peripheral venous cannulations, and lowers the risk of extravasation of vesicant drugs, and improves overall patient comfort and compliance. The chemoport, usually the diaphragm of the port can usually take up to around 100 to 1000 pricks usually, so which is much safer in a patient who requires prolonged chemotherapy post or pre-surgery in the adjuvant or neoadjuvant setting basically. This is how a chemoport looks usually post the scar heals completely. It will just appear as a subcutaneous bump, and this is one of the chemoports which we have placed in our own setup over here. And post X-ray, the chemoport basically looks like that, where there's a right intraclavicular pocket which is there where the chemoport is placed. The IJV is cannulated in the neck, and the tip of the catheter usually lies in the superior vena cava. Now I would like to call upon Dr. Kanupriya to take the case further.
Where you showed the procedure. Previous one. See, this is for everyone. There is so much of space on the slide. Use that space. This is Times New Roman 12 font. That is good for reading, for a written text. For a presentation on the screen, the smallest font size that you should use is 16. And the best font which you can use or you should use is Arial, not Times New Roman. So make use of the space. This is a small hall, but somebody sitting at the back will not be able to read it.
Sure. Thank you.
Good morning, respected dignitaries, faculty members, and my dear colleagues. I am Dr. Kanupriya from the SR from the Department of Medical Oncology. So till now we know that we have a 59-year-old lady who is married, postmenopausal, has comorbidities of hypertension and hypothyroidism, has no addictions and no significant family history of any malignancy. She was diagnosed with carcinoma left breast, infiltrating ductal carcinoma, grade 2, hormone receptor positive and HER2 receptor negative. She underwent modified radical mastectomy. The histopathology was suggestive of pathological stage T2, N2, M0. 6 out of 20 lymph nodes were positive for malignancy, LVI positive, PNI positive, and margins were free. She had a performance status of 1. So she was planned for adjuvant chemotherapy with 4 cycles of doxorubicin and cyclophosphamide, followed by 4 cycles of paclitaxel, which are all given every 3 weekly. So completing the 12 weeks of 12 cycles, she was then started on hormonal therapy with tablet letrozole, and then for adjuvant radiotherapy, she was referred to the Department of Radiation Oncology. I would now like to call Dr. Shivangi to take the case further.
Thank you, Dr. Kanupriya. Good morning, respected dignitaries, faculty, seniors, and colleagues. Taking the case forward, a post-menopausal woman presented to the OPD with left-sided carcinoma breast. Her hormone receptor status was positive, and she had undergone left modified radical mastectomy. Her final histopath showed a T2N2 disease status with 6 lymph nodes positive, perinodal spread was present. This puts her at a high risk for locoregional recurrence, so she was planned for adjuvant radiotherapy to a dose of 40.05 grays in 15 fractions. For this, a simulation was performed in supine position using a thoracic thermoplastic mold, and the ipsilateral arm was abducted. A planning CT was taken for target delineation. Our clinical target volumes included the left chest wall, axilla, and the supraclavicular region. The treatment planning was done using image-guided radiotherapy with 6 MV photon energies. A daily cone beam CT verification was done. The organs at risk were also contoured, and all dosimetric parameters were within the tolerance limits, especially the heart and the lung. So she did receive her treatment over a span of 3 weeks with no significant toxicities. Her hormone therapy was continued as previously advised, and she was kept on regular follow-up. To take the case forward, I'd like to invite Dr. Kaushiki.
Isn't it that normal fractions are 1.8 gray?
Ji, sir.
Why 2.6 in this case?
So this is a hypofractionated regime, and for cancers like for the breast, they have a lower response rate to normal dosimetric fractions. So we hypofractionate such cases. So we take a dose at a higher dose rate per fraction.
Basically, the breast and prostate cancers are radio-resistant cancers. So we do the hypofractionation to overcome the radio resistance. If we do fractionation more than 2.5 gray, we can overcome the radio resistance power, and we can convert the radio resistant to radiosensitive tumors. That's why we are giving radiotherapy in the breast and the prostate by hypofractionation.
Thank you, Dr. Shivangi. I'm Dr. Kaushiki, Junior Resident, Department of Nuclear Medicine, and I'll be discussing the lymphoscintigraphy findings of this patient. So far, we knew that the patient is a known case of left breast cancer, post-left modified radical mastectomy, post-chemotherapy and post-radiotherapy on hormonal treatment, and the patient was asymptomatic for 2 years post-cancer directed treatment, and now presented with the complaint of left upper limb pain. Since lymphedema is a common cause of hand swelling post-surgery or post-radiotherapy, the patient was referred for upper limb lymphoscintigraphy to assess if the cause of swelling was in fact lymphedema, and if so, what was the grade and level of blockage. Primary function of the lymphatic system is to carry large molecules from the interstitial space back into the bloodstream, and the movement is propelled by the skeletal muscle pumps and hydrostatic gradient. This is the pathway of the lymph flow of the upper limb, where superficial lymphatic vessels take up the large molecules, and medially along the cubital vein, the lymph flows to the cubital nodes or the supraepitrochlear lymph nodes, then to the axillary nodes, laterally along the cephalic vein to the infraclavicular nodes, and then to the axillary lymph nodes. Moving on to the procedure, we clean the first and second web spaces of the both hands of the patient thoroughly, and then inject intradermally technetium-99m sulfur colloid intradermally in both the limbs, following which images are required on the gamma camera. This is showing the procedure that is done. Post-injection, a bleb formation occurs, and the sulfur colloid is taken up by the superficial vessels through the superficial lymph nodes. It is absorbed in the lymphatic system. It goes on to the deep lymph nodes and finally into the systemic circulation. At different intervals, at different intervals during this procedure, serial images are required in both anterior and posterior views in the dual head gamma camera. Before we move on to the findings of this patient, I would like to discuss the normal findings of a person undergoing lymphoscintigraphy. These are the anterior images of the patient that underwent upper limb lymphoscintigraphy. This hot spot that looks like a star on both the sides is the site of injection. The streak-like appearance that you can see is the pathway of lymphatic drainage. And these nodular structures are the axillary lymph nodes. So these are the normal scintigraphic findings. The tracer activity should be visualized at the site of injection. There should be near symmetrical visualization of tracer at the axillary lymph nodes by 1 hour. There should be no visualization of epitrochlear lymph nodes, and no backflow of lymph nodes into the dermal or subcutaneous lymphatics. This is the 10-minute finding of the patient, where you can see the anterior and posterior image. On the right side, firstly, you can see that these are the injection sites in the anterior and posterior view. We can see that we can trace the lymphatic flow in this patient on the right side, and then the appearance of right side axillary lymph node. Whereas on the left side, there is no visualization of the lymphatic pathway or the axillary lymph nodes whatsoever. On further delayed imaging of this patient, the right-sided picture did not change much, whereas on the left side, there is visualization of dermal backflow up to the antecubital region, which is indicating the backflow of the lymphatics into the superficial plexus. On further 2 hours imaging, we can see that the intensity of the uptake on the right side has increased with more visualization of the axillary lymph nodes, and on the left side, the backflow has extended beyond the antecubital fossa with still no visualization of epitrochlear or cubital or axillary lymph nodes. Furthermore, there is visualization of activity in the liver, which signifies that our study has been completed and the tracer has reached the systemic circulation. So what were the different findings in this patient? This is the site of injection, the pathway of the lymphatics, the axillary lymph node, and the physiological uptake of the liver. This was the right side, which was the normal side, and on the left side you can see there is significant backflow. So the abnormal findings were there was no uptake in the lymph nodes on the left side whatsoever. Dermal backflow was seen, and there was no visualization of main lymphatics or visualization of collateral lymphatics. The final findings were significant and progressive dermal backflow in the left upper limb, predominantly in the forearm region, and non-visualization of left-sided cubital or axillary lymph nodes, suggestive of high-grade lymphatic obstruction, and the obstruction was at the level of axillary lymph nodes. Now I would like to call Dr. Aditya to take this case further.
Hi, good morning everyone. I hope I am audible. Myself, Dr. Vinay Aditya, Senior Resident 3 from the Department of Plastic Surgery, presenting this case. Sir, I am from Andhra Pradesh, sir, Visakhapatnam. Thank you. Under the guidance of Dr. Manish Jain, Professor, Department of Oncoplasty. So, coming to this patient, when the patient presented with the lymphedema, we have the surgical procedures. One is the physiological procedures such as the lymphaticovenous anastomosis and the vascularized lymph node transfers. And we also have the excisional procedures such as the suction-assisted lipectomy and Charlie's and modified Charlie's, which is very rare in the upper limb. We don't usually do it in the upper limb. And in this patient, we did both lymphaticovenous anastomosis and vascularized lymph node transfer. And the main principle of the lymphaticovenous anastomosis is it is a super micro surgical bypass of lymphatic vessels into a venous circulation. It reduces the lymphatic pressure and the dermal backflow, and it restores the physiological drainage. In this image, you can see intraoperatively the mapping was done to identify the lymphatics, and once the lymphatics was identified by mapping by using the ICG dye, then further we did the anastomosis for the nearby venules. So once the intraoperative ICG mapping was done, with the small incisions over the functional lymphatics, identification of lymphatics, and it is a super microvascular surgery, which means like the 0.3 to 0.0 mm diameter of vessels we are using to anastomosis, and in this case we did a end-to-end anastomosis. And coming to the outcome of this surgical technique, the limb volume reduction is seen significantly, and the significant decrease in the cellulitis episodes, and improved the quality of life and minimal morbidity and a daycare procedure. Sir, this one like around 20 to 30 magnification, sir. It depending upon the how much magnification we want at the time of the anastomosis, sir. Sir, this is the video showing the patency of the anastomosis, sir, after the anastomosis of the filling. Yes, sir. And in the same patient, we did the one more procedure, which is a vascularized lymph node transfer. It is a transfer of the functional lymph node vessels with the intact vascular supply, and it establishes the new vascular drainage pathway, and it acts as a lymphatic pump and the absorption unit. And the donor sites in this generally in vascularized lymph node transfers, you can take multiple donor sites. For example, we can take the lymph nodes from the submental lymph nodes, or the supraclavicular lymph nodes, or the groin, or from the omentum. It depends upon the surgical procedure. In this procedure, we choose for the supraclavicular vascularized lymph node, and you can see the markings here, and medially the sternocleidoid mastoid, and laterally the trapezius. And in the next picture, you can see the dissection of the supraclavicular lymph node. And in the first picture, you can see once the vascularized lymph node is taken out, like you can see by the infrared camera with the ICG dye. And in the second one, it is transferred to the axilla and anastomosis was done. Sir, contralateral. And this is the preoperative picture of the patient, and it is a post-operative picture. And coming to the measurements of the affected limb, and the first one is the mid arm. You can see preoperatively it is 42 centimeters, and post-operatively it is 36.5 centimeters, and at the elbow level it is 35 centimeters, and post-operatively it is 32 centimeters. And in the mid forearm, you can see it is like 34.5 and 30 centimeters, and coming to the hand, it is 23, and post-operatively it is 25. So this post-op follow-up is like after 3 to 4 weeks of the surgery.
I shall be taking the case further. After undergoing the previously discussed treatments, the patient was now referred to our department with pain and swelling. This image shows the pre-procedure edema of her left hand. On general examination, the patient was calm, conscious, and well oriented to time, place, and person, and she was vitally stable. Physical examination revealed edema involving the left upper limb, and on systemic examination, everything was normal. On inspection, there was a well-healed post-mastectomy scar over the left chest wall and axilla, with diffuse swelling of the left arm and inability to move the arm, along with squaring of fingers and loss of creases. There was no redness, any signs of deformity or skin breakdown, and color of the skin was normal. On palpation, the local temperature was normal, edema was of pitting type, and allodynia was present over the axillary region and arm. Allodynia is the pain due to any stimulus which is non-nauseous stimulus, like light touch or light breeze. If it causes pain, then it is called allodynia. It is a neuropathic component. Stemmer sign was also positive in this patient, which shows the inability to pinch the skin on the base of index finger. Assessment of range of motion revealed severely restricted active movements due to pain. The passive range of motion was also markedly restricted, with a global restriction of involving the shoulder abduction, flexion, and in both internal and external rotation. Measurements of the patient's both upper limbs were taken and showed the following values. Complete hematological workup was done, including CBC, liver and renal function tests, serum electrolytes, and PT-INR, and these were all within normal limits. Viral markers were also negative. Now moving on to the assessment of the patient. First is numerical rating scale, which is an 11-pointer scale scoring from 0 to 10 to indicate the severity of pain. The patient's score was 7 to 8, which falls in the category of severe pain. Her ECOG performance status, which is Eastern Cooperative Oncology Group, it was 2, which indicates that she was ambulatory and capable of all self-care, but she was unable to carry out any work activities and was up and about for more than 50% of waking hours. Next is palliative performance scale. It takes into account ambulation, activity level of evidence of disease, self-care, intake, and level of consciousness. For this patient, her PPS score was 80%. Next is palliative prognostic index. This is used to predict the prognosis of the patient, and it takes into account PPS score, oral intake, edema, dyspnea, and delirium. For this patient, her score was 1 as there was only edema present. A focused functional assessment of the shoulder was performed using activities of daily living that stressed multiple planes of glenohumeral motion, and the patient had difficulty in combing her hair, reaching overhead, reaching behind back, wearing clothes, and lifting objects. Her CATS index score, which measures the activities of daily living, was 3/6, as she was unable to perform bathing, dressing, and toileting independently. Now I'd like to call Dr. Lavanya to discuss the diagnosis and management part of this case.
Thank you, Dr. Shivangi. Good morning to our respected faculties. Myself, Dr. Lavanya, JR2 from the Department of Pain and Palliative Medicine. So moving forward, I would like to ask the audience, what do you think will be the diagnosis in this patient? Sorry? Okay. Okay. So you all have to note that in cancer patients, multiple pain syndromes overlap and they usually amplify each other. So we made a diagnosis of 3, that is the complex regional pain syndrome, post-surgical shoulder stiffness, and post-mastectomy pain syndrome in this patient. All 3 diagnoses were made because the patient's pain has neuropathic, musculoskeletal, and autonomic components. Each condition contributes to her overall disability, and recognizing all 3 allowed targeted multimodal management rather than treating only one aspect. Post-mastectomy pain syndrome is defined as chronic pain persisting for more than 3 months following mastectomy or other breast surgery, and it is characteristic neuropathic in nature, described as burning, shooting, or electric-like pain. It is commonly associated with sensory disturbances such as numbness, tingling, or even allodynia, most often resulting from injury to the endocostobrachial nerve. Although primarily neuropathic, it can secondarily lead to restricted shoulder movements due to pain inhibition and disuse, significantly impacting functional ability and quality of life. Post-surgical shoulder stiffness is characterized by progressive stiffness and loss of both active and passive shoulder motion. Prolonged immobilization may be a contributing factor. Complex regional pain syndrome is a chronic neuropathic pain condition characterized by pain that is disproportionate in intensity, duration, or typical clinical course related to the insisting tissue injury. It may develop following surgery, trauma, or other medical events such as stroke. CRPS is subclassified into type 1, where there is no demonstrable nerve injury, and type 2, where a definable nerve lesion is present, with a CRPS not otherwise specified category used when clinical features are suggestive but full diagnostic criteria are not met. CRPS manifests as sensory hypersensitivity, causing severe pain, hyperalgesia, vasomotor dysfunction, causing limb swelling, and motor involvement, leading to reduced shoulder mobility. The Budapest criteria help us diagnose CRPS based on clinical symptoms and signs across 4 domains. The diagnosis requires ongoing pain that is more severe than expected for the initial injury. The patient must have symptoms involving at least 3 of the 4 areas, that is, sensory, vasomotor, pseudomotor or edema, motor or tropic, and on examination must show signs in at least 2 of these areas. These included increased sensitivity to pain, change in skin temperature or color, swelling or sweating changes, and reduced movement or weakness. Finally, no other condition should better explain the patient's symptoms. So since this patient had overlapping pain syndrome, her management was multimodal, addressing edema, pain, inflammation, neuropathic stiffness, and even her psychosocial distress. Medications were tailored to target mixed pain pattern. Steroid ganglion block helped her with her CRPS by reducing sympathetic overactivity, improving pain and edema, whereas the suprascapular nerve block provided significant relief in her restricted shoulder movement. We also gave her counseling and emotional support. Psychosocial support was also given by our medical social worker. She has been in touch with the patient for the past 3 years. This image demonstrates the intermittent pneumatic compression device that we used in this patient to stimulate lymphatic flow. The 4 pillars of complete decongestive therapy, the manual lymphatic drainage, compression bandaging, range of movement exercises, and even skin and nail care were also addressed in her. Pharmacological management was done based on the WHO pain ladder pattern, where mild pain is treated with non-opioids, moderate pain with addition of weak opioids with or without adjuvants, and severe pain with strong opioids. In some cases, when the pain is not managed even with step 3, we will add interventional pain management like the nerve blocks as step 4. The patient was initially managed with weak opioid and adjuvant medications. However, due to inadequate pain control, escalation to strong opioid therapy was required. Pain and limb swelling persisted despite escalation to strong opioid therapy. She was then planned for interventional pain management with CM-guided stellate ganglion block and UST-guided suprascapular nerve block. 2 sittings were done 1 week apart. Sir? Location? So it's located in between the so it's located in the it's located in the cricoid thyroid cartilage medial to the carotid artery. So the location, yeah, when we are palpating, we palpate is like. नहीं सर पता तो है. Neurolytic block. So in neurolytic block. So neurolytic में we will use alcohol based substances and we will permanently destroy the nerve.
Yes. Better relief.
Okay.
Sir, आप starting से ही कर रहे हैं. You were doing, sir, I know.
So moving forward, the suprascapular nerve block was done in this patient for her restricted shoulder movement. This image illustrates the landmark-based approach. Landmark-based approach to supraclavicular nerve block. Spine of scapula is identified, and a line is traced along, while the other line is drawn in parallel to the vertebral column, bisecting the scapula. Needle is then inserted at the point where this reference lines intersect, directing it towards the suprascapular notch, where suprascapular nerve passes. As you can see in this image, the transducer was kept above the spine of patient's scapula to visualize trapezius and the supraspinatus muscle. The hyperechoic linear structure is the transverse scapular ligament, which forms the roof of supraclavicular notch. Needle is advanced in plane toward the suprascapular notch, and local anesthetic was deposited around the suprascapular nerve below the transverse scapular ligament. Moving on to stellate ganglion block, which help in CRPS by reducing sympathetic overactivity, improving pain and edema. The inferior canal ganglion fuse with the first thoracic ganglion to form the stellate ganglion. It is 2.5 cm long, 1 cm wide, and 0.5 cm thick. It is located in front of the interspace between C7 and T1 intervertebral bodies. Stellate ganglion block is primarily indicated in conditions where sympathetic overactivity contributes to pain or vascular compromise, especially in head, neck, upper limb, and upper thorax. Under fluoroscopy, correct placement of the needle shown by anterior, posterior, and lateral views with spread of contrast solution. After confirmation of proper needle placement, medication was injected. The location is confirmed using needle pointer. Needle was then inserted under fluoroscopic guidance on the ventricular body. Needle is advanced until it touches the vertebral body, slightly withdrawn, and careful aspiration is performed to exclude intravascular placement before injecting the contrast. Contrast is then injected to the prevertebral space, following which the local anesthetic is slowly administered under continuous aspiration and monitoring. To understand the evidence behind stellate ganglion block in CRPS, I will now briefly highlight two reviews. The first is a 2024 meta-analysis focusing on randomized controlled trials evaluating stellate ganglion block for CRPS. This second review focuses specially on upper limb CRPS and also evaluates functional outcome and safety. Taken together, these reviews suggest that stellate ganglion block provides meaningful pain relief and functional improvement in CRPS patients. Stellate ganglion interventions improve pain and disability in upper limb function. As you can see, we also did early post-procedure shoulder mobilization, as it is very crucial in improving the long-term functional outcome in this patient. I will now briefly outline the case timeline of this patient. So this was a 59-year-old female with hypertension, hypothyroidism, and she was diagnosed with invasive ductal carcinoma of left breast in July 2021. Modified radical mastectomy was performed in 2021 July, and she completed 12 sessions of chemotherapy and 3 weeks radiotherapy and targeted therapy. Early in 2024, progressive left arm swelling was seen, and she underwent reconstructive microvascular surgery. Patient was alright for 3 months, then again pain and swelling over arm reappeared. In March, excruciating pain in left arm, shoulder and neck, and she was started on the World Health Organization pain ladder step 3 for 3 months. Because of severe pain, we did the intervention stellate ganglion block and intra-articular shoulder block on 12th of June 2025. Now let's see how through multidisciplinary treatment, the outcome has changed in this patient through these two videos. This is a pre-procedure video.
पिछले 3 महीने से मेरे हाथ में बहुत ज़्यादा दर्द हो रहा था, बट अभी 15 डेज से तो इतना ज़्यादा है कि मैं बिल्कुल ही अपना हाथ नहीं उठा सकती हूँ। फिंगर्स भी बड़ी मुश्किल से मेरी मूव होती है। हाथ ऊपर उठा के दिखाइए। I can't lift my hand at all, बिल्कुल भी नहीं हो पा रहा है और बहुत ज़्यादा तकलीफ में हूँ मैं।
And this is the post-procedure video.
Earlier मेरा हाथ बिल्कुल फिंगर्स ही मूव हो रही थी, मैं बिल्कुल अपना वॉशरूम भी नहीं यूज कर सकती थी, नहा भी नहीं सकती थी, बाल भी नहीं बनते, कपड़े भी नहीं पहन सकते। बट आफ्टर द प्रोसीजर अभी मैं अपना हाथ इतना अपने आप से उठा सकती हूँ और विद सपोर्ट मैं ऐसे इतना उठा सकती हूँ इस हाथ को। अभी आई एम नॉट डिपेंडेंट ऑन एनीवन, मैं अपना काम खुद कर सकती हूँ।
Compared to the baseline, the post-procedure video demonstrates reduced pain behavior and improved shoulder mobility, confirming functional benefit from the multimodal management. Now, this was the extent of hand swelling when the patient first presented to us. After the procedure, now look at the image of a hand with reduced swelling. Now, I would like to invite Dr. Nipun Lamba sir for conclusion.
Sir, personally, this is one of the cases which makes me feel how blessed we are that हमें इतनी opportunity मिली to do the quality of work we are doing for our patients thanks to our institute. It shows the importance of multidisciplinary team management, that how a patient till now, matlab from her journey from the start, how various departments have collaborated. Sir, no words, and obviously, sir, thanks to Dr. Hemant Vanota sir, who has guided us all along the way, and this is like an achievement for us that we are able to rehabilitate and make a patient pain-free, and really a blessing to learn and do such kind of quality work in our institute, in our SRCC Shri Ram Cancer Center. Thank you, sir. And also, I would like to thank all the residents, all the concerned departments, Shikha Dal ma'am, Sumit sir, Manish Jain sir, Department of Nuclear Medicine, Surgical Oncology, everybody, Ajay sir, who have guided us in making this presentation, and making it worthwhile of our time. Thank you, sir.